All right, people are flowing in.
Okay.
Welcome, everybody. Good evening. All right, let's kick it off. Just about 100. I think that's a fair number to give it a go. All right, good evening, everybody. Thank you so much for joining us. For those I have not had the opportunity to meet, my name is Chris Gross, and I serve as the National Sales Director for Optimal Balance Pharmacy, a 503A compounding pharmacy based in Houston, Texas, licensed in more than 33 states. Tonight's session will be recorded and posted to the Optimal Balance YouTube channel by next week. I've been really looking forward to tonight. As this education series continues, we're getting more specialized with each conversation, and peptides are opening an exciting, important discussion around recovery, performance, and individualized patient care. That is exactly what Dr. Adrienne Towsen brings to us. She's a board certified orthopedic surgeon with more than 20 years of experience and the founder of Towsen Clinic, where she integrates peptides, hormones, and performance medicine into a comprehensive approach, helping patients heal and live better. We are truly, truly grateful to have her with us tonight. Dr. Towsen, welcome. The floor is yours.
Thanks so much. Thanks for that lovely introduction, Chris. And thank you to Optimal Balance Pharmacy for inviting me to give this talk. And most of all, thanks to everybody who's spending their evening with us. And I really hope to make it worth your time and attention. So I want to start by telling you that I spent a lot of time thinking about why an orthopedic surgeon should be having this conversation. So I spent 21 years in traditional orthopedic surgery and sports medicine. I was a knee and shoulder surgeon, mostly shoulder in the later years, and I absolutely loved it. So nothing better than a great lineup of cases with a stellar team. And for any of my surgeon colleagues on this call right now, you know that the OR is a special place, and so you understand exactly what I mean. Interestingly, peptide medicine had not entered the conversation in my orthopedic practice as recently as a year and a half ago. So I left my practice just a little over a year ago, and I'm sure it would be in the conversation now. Peptides are increasingly becoming part of the orthopedic and sports medicine conversation, whether we're comfortable with it or not. But I must say, I've reviewed several different orthopedic websites which have lots of peptide sections and things about them on them already. So I think there's many practices that have already started to incorporate them in some way, shape, or form. Patients are asking about them, athletes are using them, weekend warriors are using them, clinicians are discussing them, and the orthopedic literature itself is beginning to address them. So we have a systematic review looking at specifically at BPC 157 out of HSS. We have a statement about peptides from the AOSSM. We have other reviews looking at peptides more broadly and great sources such as the Journal of Orthopedic Experience and Innovation. So I don't think the question anymore is whether orthopedic clinicians should know about peptides. We need to know about peptides. The harder question may be, what should we do with the evidence we actually have? And then how do we advise our patients? And that's what I'd like to speak about tonight. So I'm not here to tell you that peptides are the magic answer to every unsolved orthopedic question we have. And I'm certainly not here to tell you that the science is settled, because it isn't. But I'm here to talk about a much more interesting question. Could manipulating selected biological pathways eventually become another tool in our orthopedic toolbox, helping the right patient recover, adapt, and preserve function? And what does responsible clinical use look like while the evidence is still emerging? And I promise I have more than just this slide, so let's keep going. So a couple of important disclosures before we continue. So the educational content here is for licensed prescribers. Compounded preparations are not FDA approved and are not reviewed by the FDA for safety or efficacy. I do have a clinical, some of the compounds discussed tonight are largely off-label or investigational. I do have a clinical and advisory relationship with Optimal Balance Pharmacy. I am intentionally not giving dosing protocols tonight There are not validated orthopedic protocols for many of these compounds, and individual prescribing decisions need to remain just that: individual clinical decisions made by the provider based on the patient in front of you and the clinical scenario. And throughout tonight, nothing I'm saying establishes a standard of care, but I'm going to try to be deliberate about distinguishing three things: what we know, what we think may be happening, and what we simply don't know yet. So for 21 years, I treated the end result. I was largely treating the downstream consequences of failed or injured tissue. Orthopedic surgery is extraordinarily good at fixing anatomy or replacing the worn out joint, but doing these things and creating recovery are not the same. I can put an ACL graft in the exact right position. I can repair a rotator cuff tendon to the biologic footprint on the greater tuberosity, but I can't make the patient biologically capable of healing it. So how did I actually get here? So I had a sports medicine practice for 21 years, taking care of high school and college athletes, but more so weekend warriors, midlife adults. That was kind of more the practice that I had. And my job was really to identify the structural problem and fix it, often surgically, but not always. Over the years, though, one question increasingly bothered me: how could I do the same surgery on two people, same technique, same implants, same rehab protocol, and watch them have completely different recoveries? You know what I'm talking about. It happens all the time, especially in my rotator cuff world. I feel like it was just a constant scratch in the head. Why is this person doing better than that person? They should really have the same recovery. And that question eventually took me upstream. Took me upstream to learn about metabolic health, hormonal health, counseling people about their sleep, their nutrition, their exercise, and ultimately into this world of health optimization, including peptide medicine. And so this happened just over a year ago, and I actually opened my own clinic, the Towsen Clinic, exactly 6 months ago today. So I'm still taking care of some of the same patients that I had in my ortho practice, actually. I'm just meeting them at a different point in the continuum. And instead of only asking what's broken or what's torn, I'm asking what is making this person vulnerable to breaking and what is preventing them from recovering. So repair was never the point, was never the actual endpoint. Function was. So repairing anatomy was a critical part of my job, for sure, but it wasn't the only part. Restoring function was always our ultimate goal. So a repaired tendon, rotator cuff, or otherwise that can't load, or a replaced joint in a sarcopenic patient, those are structural successes, but they're functional failures. And we definitely deal with that from time to time. So again, thinking about same surgery, different outcomes. Take two ACL patients. One enters surgery resistance trained, metabolically healthy, good muscle mass, adequate protein intake, restorative sleep. The other is sarcopenic, insulin resistant, deconditioned, sleep deprived. You can reconstruct the ACLs beautifully in both of those, but you have not created the same biologic starting point. We'll go back a sec. Sorry. You cannot out operate, no matter how good you are, a suboptimal biologic environment. So this was our term. We have a lot of terms in orthopedics, and I don't know, this may be in other specialties too, but it was something I heard a lot, especially in my residency. Used to say the patient had poor protoplasm when they did badly. It was our sophisticated way of saying like they didn't heal as well as we hoped. It's kind of their tissue. It was a poor outcome. And the reason behind that, we would probably not really have the framework to fully understand. But in retrospect, I think we were describing a real biological problem: sarcopenia, insulin resistance, hormonal imbalance, lack of good protein intake, poor sleep, reduced mitochondrial function. And medicine evolves partially because of these unanswered questions and not accepting we don't know, not saying, oh, they just have poor protoplasm. That's why they didn't heal well. That's not the end of the conversation. And that doesn't mean that we manufacture an answer. It means that we start asking better questions. So look at our basic, we have two patients here, one operation. The optimized patient, again, adequate protein intake, resistance training at baseline, controlled glucose, the unoptimized patient, low muscle mass, elevated hemoglobin A1C. Again, as I mentioned before, we cannot out-operate a suboptimal biologic environment. If we look at our basic orthopedic algorithm, we start with pain or loss of function. We go through the imaging, the physical exam, all the things we know to do. We come up with a diagnosis, and that most of the time will lead us to some type of a mechanical solution. So this algorithm is correct, it's necessary, but in my opinion, it's also incomplete because healing is not purely mechanical. It's mechanical, but also biological and metabolic. And the mechanical solution only succeeds in the correct biological and metabolic environment to support it. So let's take a look at how tissue actually heals. The process will start with hemostasis. So we have platelet aggregation, we have clot formation. Then we move into inflammation and cellular recruitment. So we've got immune cells, growth factors, fibroblasts, and progenitor cells, all going to that zone of injury. Then we have angiogenesis and matrix deposition. So we need new vasculature to be established. Anything that heals in our body needs blood flow. Collagen is laid down. We get the structural scaffold of repair, and that begins to form. And then our final stage is remodeling and maturation. And this is what is going to take a long time. Collagen gets reorganized along the lines of mechanical stress. Functional loading drives maturation. And we know that this phase takes months, if not years. Every step along that cascade needs a favorable environment. Hemostasis needs adequate vascular function. Inflammation needs immune competence. Cellular recruitment needs growth factor signaling. Angiogenesis needs metabolic support. Matrix deposition needs protein and micronutrients. Remodeling needs mechanical loading, balanced hormone environment. Maturation needs time and quality sleep. So peptides enter the conversation now as potential biologic modifiers at specific stages of this cascade. I know you've been on the edge of your seat waiting for me to get to this part. So what is determining that environment? Again, we can run through these. Sleep and nutrition gives us the anabolic drivers. Protein and restorative sleep are so important. Metabolic status, insulin sensitivity, body composition. This modulates our healing capacity and inflammation. The hormonal environment, balance, the hormone balance and inflammatory burden set the anabolic catabolic ratio. Peptide signaling, here we go. So when we identify an interesting signaling molecule, I don't think the first question should be, how much should I give? The first question should be, what biological process am I trying to influence? And is everything else required for that process actually present? All of these things are important. Peptide signaling can become an incredibly useful tool, I think, but it's an adjunct. It is not the foundation. So what is our, let's say, orthopedic version of optimization when we're trying to get someone ready for surgery? I mean, I think particularly in recent years, we have really, especially in the orthopedic sports medicine world, have thought more about optimization, have thought more about biologics, even in the OR. But what are we really able to do within the confines of our healthcare system and the volume-based practices that so many of us had? Our preoperative checklist looked something like this, I would suspect. At least it did in my practice. Smoking cessation, try to get people to stop smoking. Did it happen? Sometimes we wouldn't know. Glucose and hemoglobin A1C targets, especially before joint replacement, correcting vitamin D deficiency, counseling on weight loss. I mean, we do this all the time. It's such a big part of orthopedic degeneration, particularly with our hip and knee patients. Prehab referral to physical therapy. Try to get people a little stronger, try to improve their range of motion, try to teach them about what they're going to need to do after surgery. But what did that usually consist of? Maybe 1 or 2 PT sessions prior to surgery. So that does not equal a strength training program to really optimize someone as much as possible. And then occasionally we were delaying surgery until they were medically ready. But what was our endpoint there? It was getting someone healthy enough to operate on safely. It was not necessarily creating the best possible biological environment for recovery. So those are very different goals. And we could certainly go on and on about the healthcare system and how kind of handcuffed we are in a lot of ways. But I think, again, getting someone healthy enough to get to the OR does not necessarily mean they're optimized. So what is real orthopedic optimization? Give me an M, a U, an S, a C, an L, and an E. It is muscle. Muscle is orthopedic medicine. So if you forced me to pick the single most important intervention in orthopedic optimization, it's not a peptide, it's muscle. Muscle determines everything: joint health, joint stability, metabolic reserve, rehabilitation capacity, functional independence, longevity. Let's look at what happens to a knee. So orthopedic injury is extraordinarily good at destroying muscle. Even orthopedic surgery, when someone has an ACL reconstruction or a knee replacement and there's immobilization required, you've seen this. The quad just disappears. It takes days, maybe a week, and you've already got this skinny thigh following the surgery, and it takes forever, or the injury, and it takes forever, it seems, to rebuild that. And how does that happen? Getting it back requires neuromuscular retraining, progressive resistance training, adequate protein and caloric intake, a favorable hormonal environment, sleep and recovery, which drives adaptation, and time, which is truly the rate limiting factor. So when I was operating, I can tell you, yes, I reconstructed the ACL, but I couldn't do the squats for the patient. I couldn't make sure the patient was eating the right amount of protein. I couldn't make sure the patient was sleeping or training consistently in the way they should be for 6 months, and neither can a peptide. And that part of it, the rehabilitation is the part of it that really restores the function. And honestly, that part of it, a lot of it relies on the patient. It's a human thing. They either need to do it or they don't, and it certainly affects their recovery. So here is just a diagram, another look at it, at all the variables we're talking about, and where do peptides fit, potentially in any one of these areas. But again, as an adjunct, adding a peptide to a patient who is not sleeping, not taking in enough protein, not doing the rehab, that's not optimization. That's just an expensive distraction for the patient. So each of these inputs are important. Rehabilitation gives you the mechanical stimulus. Nutrition is the substrate. Sleep gives you that anabolic window. Growth hormone, protein synthesis, tissue repair, all of those are predominantly nocturnal events. Hormone and metabolic health influence the environment. Peptides may modify specific signaling pathways within this framework. And that's what makes these compounds so interesting in orthopedics. So what are the endpoints that matter? We need to be able to measure something. We need to look for pain being resolved, swelling being reduced, range of motion return, strength gains, a return to activity. Once again, those functional returns. So if I'm going to intervene, I want to know what outcome I'm trying to change. My patient ultimately does not care whether I changed a signaling pathway. They want to know that they can climb the stairs again. They want to be able to pick up their grandchild or get back on the dance floor. We must define the target before we prescribe. We want to know what success looks like before we actually start. So where do peptides fit? We spent a good bit of time setting the stage for this. Appreciate your patience. So 3 main buckets: recovery, performance, optimization. None of these categories automatically establishes efficacy. And this is where I want to take a moment to distinguish between biological plausibility and separate from clinical proof, without pretending that biological plausibility has no value. So with looking at the peptide evidence hierarchy, we have mechanistic evidence, tells us where to look. Preclinical evidence helps us formulate hypotheses. Early human experience may tell us something deserves more rigorous study. And randomized controlled trials, when we have them, give us a much higher level of confidence about efficacy and safety. So those are all different levels of evidence, and a lower level doesn't mean it's worthless. It means our certainty, and therefore our claims, need to be proportional to the evidence that we have. So this is a good time before we go any further to look at where the regulation sits. The regulatory landscape is moving quickly, and current status needs to be verified before prescribing. So I also want to keep these lanes separate. I'm sure most everybody on this call knows about the advisory committee meetings that happened last month. And I think those were generally very positive because we know that 6 of the 7 compounds that were discussed actually got favorable recommendations. Of course, this doesn't mean that they are FDA approved. This means that they got favorable recommendations from the advisory committee, and now they go before the FDA. But what I also want to keep in mind is regulatory status and scientific evidence are different questions. So something being available doesn't prove it works. Something being under regulatory review doesn't tell us what future efficacy trials may show. So throughout this discussion, we kind of need to keep those lanes separate. I also want you to keep this in mind. Medicine evolves with uncertainty. This is not unique to peptides. Orthopedics certainly has this. I've practiced long enough to watch things that were once considered the standard of care become absolutely obsolete. I think every patellofemoral pain in my residency got an arthroscopic lateral release. I have not done one of those since I left my residency in, what year was that? Oh, shoot, 2003, a long time ago. Same thing with rotator cuff repair. I did not do one arthroscopic rotator cuff repair during my residency. That came about, that transition was coming about when I went into my fellowship, and I learned how to do it in my fellowship. And I will tell you, even my chief year of residency, the guys that were doing all of our sports medicine, big guys, I was in Pittsburgh, the Pirates doctor was saying, like, there's no way you can get the view you need. There's no way you can do the same kind of rotator cuff repair through a scope that you can do open. Well, guess what? You can, if not better, right? And we've adopted that. I didn't do one open rotator cuff repair in all of my years of practice, not one. So again, I think it's just important to recognize how things change and evolve in medicine. I think another good example is DVT prophylaxis after joint replacement. So when I was coming out of my residency, some of our big joint guys were switching over to aspirin. It was around that time. Before, it was always, hardcore Coumadin most of the time. And that is not without its own potential for risks and complications with patients. So that was, again, like 2003. 2006, I came to my practice that I just recently left, and the senior joint guys there, I was doing some total knees at that time. I said, I'm going to put my patient on aspirin. They crucified me. They're like, there's not enough data. There's not enough study. We can't do that. We use Coumadin. This is our protocol. You have to use Coumadin. So I can clearly remember charts piled up on our desk every week with these yellow sheets in front of them that we had to do everybody's INR, adjust their Coumadin dose. And it was crazy. And people had issues. Their INRs would get sky high, and there were all kinds of things that would go wrong on Coumadin. So certainly a year later, not every patient, but a lot of patients at that point, it became more commonplace to use aspirin. So let me be clear. I'm not comparing the evidence for aspirin to the evidence for BPC 157. And I'm not predicting that the future will vindicate every peptide we're talking about tonight. That's not my point. But my point is medicine moves by continually reassessing the evidence, the benefit, the risk, and the alternatives. So today's uncertainty should not be mistaken for tomorrow's answer in either direction. I think you need to take the middle position, or at least this is the position that I'm taking right now. So I think there's 2 intellectually easy positions to take in emerging medicine. One is, that sounds so exciting, so let me just jump on that train and go for it. I don't think that's the right answer. The other is, there isn't a level 1 randomized controlled trial, so there's nothing here worth discussing. And I certainly don't think that's a good answer either. The harder position to take probably is somewhere in the middle. You need to try to understand the biology, understand the evidence hierarchy, understand the limitations, select patients carefully, be transparent about the uncertainty, talk to your patients, measure outcomes, monitor for harm, use appropriate sourcing. That is a key. We'll get back to that later. And keep changing your practice and keeping your mind open as the evidence changes and emerges. Because clinical curiosity and clinical rigor are not opposites. All right. BPC 157, why orthopedics is paying attention. So this is probably the compound that has attracted more attention in orthopedics and sports medicine than any other peptide we're discussing tonight. And importantly, we are no longer talking about something that exists exclusively on social media or on wellness websites. The 2025 HSS Journal Systematic Review specifically examined BPC 157 from an orthopedic sports medicine perspective. It identified or included 36 studies. 35 were preclinical, one was clinical. So that right there tells you almost everything you need to know about where the evidence currently sits. The preclinical findings, however, are interesting, dare I say exciting. There are signals involving growth factor and angiogenic pathways, inflammatory signaling, and functional, structural, and biomechanical outcomes in muscle, tendon, ligament, and bone injury models. That's why orthopedic clinicians are interested. That's why orthopedic patients are interested. But the human evidence is extraordinarily limited. And that systematic review found no clinical safety data. So here's where we have to be precise. The line that I will not blur, mechanistic plausibility does not equal proven clinical efficacy. But the converse matters too. I want to be equally careful about that. The absence of high quality clinical trials, human clinical trials, does not make the preclinical evidence meaningless. It tells us that how much certainty we're able to have, and it tells us that we need more investigation. So that's different. And this is where I land as a clinician right now. I use BPC 157 in selected patients. I've used it myself with benefit. And I'm comfortable saying that. I'm also comfortable saying that we need better human data. Those statements are not contradictory. My job is not to turn uncertainty into certainty in either direction. My job is to understand the evidence hierarchy, assess potential benefit and potential risk for the individual patient, communicate what we know and what we don't know, obtain appropriate informed consent, and that's key, monitor the patient, measure outcomes, and change what I do as the evidence emerges. And that's what we need to do in medicine, I think, across the board. So here's what we have and what we don't have. What we have, substantial preclinical interest and animal model data, mechanistic data on relevant pathways, extensive anecdotal clinical use and growing clinician interest, and a compelling biological rationale that's worth investigating. What we don't have, of course, we know this, large, high-quality human randomized controlled trials, and certainly not at all, but not in musculoskeletal indications. We do not have standardized orthopedic indications or patient selection criteria. We don't have validated post-op or pre-op, for that matter, protocols with clinical endpoints. And we don't have robust long-term safety data or definitive dosing standards. So there's a lot of unanswered questions, of course, still. So let's talk about another compound that is sometimes used together with BPC 157 called TB500. So it's often paired with BPC 157 because their proposed mechanisms are complementary. Cell migration, angiogenesis, cytoskeletal organization, tissue remodeling, and inflammatory signaling. But here's another evidence problem. Thymosin beta-4 is not automatically TB500 research. So those terms can be used interchangeably too casually sometimes. TB500 is a synthetic fragment of thymosin beta-4. They are not the same thing. So when someone cites a paper, you want to know what molecule are they actually talking about. And again, why the combination? They're frequently used together. They're referred to as the Wolverine stack, and they are, again, theorized to target different components of that recovery process through complementary mechanisms. So reduction in the prolonged inflammatory burden, support of soft tissue healing, and improved rehabilitation tolerance. But here's another risk that doesn't get talked about as much. It's worth raising this point. you may have actually muted part of the warning system without actually accelerating tissue maturity to the same degree. So I would tell patients feeling better is not necessarily the same as being healed, even if these peptides are allowing some processes to be perhaps more efficient or perhaps even a little bit faster. But you know what? This happened all the time without the addition of peptides. Certain patients would feel better sooner than others. We would know our timelines. We would know what we expected for tendon and bone healing, for just bone to bone healing, for any kind of soft tissue integration of a graft. But patients often do what they want. So how many times did, they come in without a sling on when they're supposed to have a sling on, or tell you or maybe not tell you, or their spouse kind of, ratted on them, telling you something they were doing that they weren't supposed to be doing. Sometimes they got away with it and sometimes they didn't. So we don't necessarily know if this would give them another opportunity to feel better than they should too soon. So we just have to reiterate what our protocols are as far as the rehabilitation process. I don't think we go crazy accelerating our protocols if we add peptides to the mix. So peptides are not a fast forward button. Again, graft incorporation, tendon to bone healing, fracture consolidation, tissue maturation, all of these things matter. So let's look at the continuum. Traditional medicine often gets someone from injured to healed to functional. Many of my patients, especially now, don't want to stop at functional. They want strong, resilient, and high functioning. So in ortho, I think we get them healed and cleared. Rarely do we see patients beyond maybe 3 to 6 months post-op, maybe 12 months, depending what the procedure was, unless they're having a problem. But the work to achieve that truly optimized patient, that goes long beyond healed and cleared. So my favorite population is that midlife athlete, not necessarily an elite athlete. And as I mentioned before, this was the majority of my practice in ortho, and it's the majority of my practice now. These are people who, we have the woman in her 50s who wants to ski. We have the man in his 60s who wants to keep playing tennis. We have the 48-year-old man or woman who wants to go to the gym and train hard and recover well. So at this stage of life, they're dealing with hormonal changes, body composition shifts, accumulated orthopedic injuries, and longer recovery windows. So what are they actually asking for? They're not asking me to make them 25 again. They're asking me to preserve capacity, to not feel like their body is working against them. And in my opinion, this is a very legitimate and also underserved goal. Stress, recovery, adaptation. So when we look at this, we are seeing this slide, we're seeing that training works through stress, recovery, and adaptation, and that's a healthy cycle. When recovery becomes inadequate, repeated stress stops producing adaptation and starts producing breakdown, that's an unhealthy cycle. So interventions in this space can target sleep, protein utilization, glucose metabolism, hormones, inflammation, mitochondrial function, body composition, recovery signaling. So this is when we can talk about your growth hormone axis secretagogues. Very interesting. So these compounds potentially interact with physiologic growth hormone release, IGF-1 signaling, body composition, sleep, and recovery. But this isn't casual performance prescribing. This is, again, where patient selection matters. Malignancy history, these are going to be your hard stops. Active or recent malignancy, unmanaged glucose intolerance, untreated sleep apnea, tested competitive athletes, patients who want the peptides instead of the training. And some of this relates back to BPC 157 and TV500 as well, but certainly also in the growth hormone secretagogue category. And if somebody wants a peptide instead of getting those foundational things squared away, and they don't want to train, they don't want to do what they need to do, then they're not a candidate. That requires a different conversation. So two different questions I think we're looking at when we're discussing standard orthopedic care versus optimization medicine and the potential inclusion of peptides. We're asking in orthopedics, basically, what's broken? Optimization is asking, where is the person losing capacity? So now we're looking at muscle mass, we're looking at visceral fat, we're looking at insulin resistance, hormone status, sleep, nutrition, etc., the entire biological context. So orthopedics tends to meet people at the acute event, but it's quite likely that maybe 10 years before that happened, there was vulnerability which allowed that event to occur. So optimization hopes to intervene sooner. Here's that cycle. We see pain that causes inactivity. We see inactivity causing muscle loss. We see muscle loss causing metabolic decline causing weight gain causing greater load on the joints, and greater load on the joints causing more pain. So it really is a vicious cycle. But what we can see is that that knee pain, or just the knee itself, is living inside a much larger physiological problem. So that brings us to a little bit more of a discussion about metabolic health. Metabolic health is musculoskeletal health. Obesity and joint loading. Every pound of body weight applies approximately 3 to 4 pounds of force across that knee joint during walking. And that mechanical consequence is cumulative. So all of us that treat orthopedic patients, did joint replacement, hips and knees in particular, as well as other types of surgery, realize that obesity is a huge problem in our country still, and it walks into our office every single day. Insulin resistance and inflammation. Chronic low-grade systemic inflammation impairs the tissue healing. We have cartilage degradation, and it blunts anabolic signaling. Sarcopenic obesity, the worst phenotype that comes into the orthopedic office, right, for orthopedic outcomes. This is increasingly common in our midlife patients as well. Loss of muscle with concurrent fat gain. And this is a self-reinforcing cycle. Reduced activity creates metabolic decline, and then metabolic decline reduces your recovery capacity. Reduced recovery, reduced activity, and it compounds over time. So that brings us to talking about tirzepatide or the GLP-1 or semaglutide, but what tirzepatide therapy can offer and how we should look at this in our orthopedic world. Tirzepatide is a GLP-1 GIP agonist, and this can be highly relevant for orthopedic patients because meaningful weight loss can lead to so many other downstream positive effects, especially in our orthopedic patients, with reducing joint load and improving their overall metabolic health. But of course, we need to also pay attention to not just how many pounds did you lose, but what did you lose? So we want to make sure that if someone's losing weight and if someone's losing substantial weight, that they are not also losing meaningful lean muscle mass. So you may be solving one orthopedic problem while contributing to another. So in my world, this type of therapy lives alongside a lot of guidance and counseling on adequate protein intake, progressive resistance training, and body composition monitoring. So the goal is not simply a smaller human. The goal is a metabolically healthier and stronger human. So we can also talk about MOTS-c. I think this is another very interesting area of discussion. So mitochondrial signaling and metabolic communication are very interesting to discuss here. It's a good example, though, of where clinical enthusiasm may be running just slightly ahead of human data. So my certainty when I talk to patients about this compound or any compound has to be proportional to the evidence. Interesting doesn't mean established, but it doesn't make it uninteresting. And there are lots of areas where MOTS-c is actually quite interesting in the orthopedic world. Articular cartilage, osteoarthritis, bone remodeling, osteoporosis, skeletal muscle preservation, and performance. So there's preclinical data to suggest that there's improvement with cartilage, the quality of cartilage and cartilage restoration potentially, suggesting lack of or reducing inflammation and reducing matrix degradation. In skeletal muscle, there's improved mitochondrial efficiency, metabolic stress response, and physical performance. And then there's also interest in osteolysis, as far as potential loss of or induced inflammatory bone loss, only again in an animal model. So the other thing to think about is, do peptides belong in the discussion with regenerative medicine? So I think we need to define this. Regenerative medicine means restoring damaged tissue to its normal structure and function. And that's a very high bar. So this should actually mean original structure and function, which I think is, again, hard to achieve. And I don't think we can necessarily expect peptides to do this. The words that we tend to use interchangeably and should not include symptoms, repair, and regeneration. If a patient feels better, that's a symptom outcome. It's real and it's clinically valuable. Repair means that damaged tissue is healed. Often that's in the form of scar. Their structural integrity has been restored, but the scar tissue is not native tissue. There's different mechanical properties there, as well as different failure characteristics. Regeneration is a much higher bar, trying to get original tissue architecture and function restored. So that's a very hard target to achieve. Let's look at the example of a rotator cuff. Again, this was the thing I treated the most in my orthopedic practice. If I had a patient with a degenerative partial rotator cuff tear who felt dramatically better after some intervention, whether that be a PRP injection, whether that be using BPC 157, the patient goes back to golf. That's valuable, but does that prove that we regenerated that tendon? I mean, you could follow up with an MRI and see what it actually looked like, but it doesn't give you that proof. Did the tear actually shrink or repair itself? Did the collagen architecture normalize? Did the structural findings change? Symptom response and tissue response are separate variables. So we need to be thinking about how to treat the patient, I think, with this type of a cascade of figuring out why something actually hurts. Patient presents with tendinopathy or that degenerative partial tear. I'm not immediately thinking BPC 157 now. I'm thinking, why does that tendon hurt? What's changed? Chances are that patient's MRI looked the same the week before they came to see you, and then that day they came to see you. Was it the training load? Was it something biomechanically in what they're doing? Was it the accumulation of muscle weakness over time, metabolic dysfunction, other factors, obesity, menopause, all of these other things that can come into play? So again, here, a peptide might be part of the answer, but we really want to get to the foundational layer first and work our way up to that peptide. It's most often not the right starting point. So again, if we look at the order of operations when we're considering peptides, this is no different than how we should go through anything that we're doing as a clinician. The end of the day, we have to practice medicine and go systematically through a stepwise approach with no matter who we are treating or what we are treating. We need to make a diagnosis. We need to evaluate the mechanical environment and loading. We need to discuss and assess rehabilitation and resistance training, nutrition, sleep, recovery, metabolic and hormonal optimization. And then, and only then, at sort of the top of this pyramid, should we incorporate or discuss peptide therapy. And there are 5 questions that I really want anyone to ask themselves before considering peptide therapy. What are you treating? So you want to define that clinical target precisely, not a vague complaint, a specific diagnosable condition or physiological deficit. What biological pathway am I attempting to influence? So be specific. What stage of that cascade? We talked about that healing cascade earlier on. What signaling pathway are we trying to affect? Number 3, what evidence supports the hypothesis? Again, we may not have the level of evidence that we think we should have, but with what we know, we need to be honest about that evidence hierarchy and decide if what we know supports what we want to do. Number 4, what else must happen for this patient to improve? identify every other variable that we've been talking about here in every patient, every variable in that recovery equation, and confirm that they've all been addressed to the best of your ability. And number 5, how will I know whether or not it worked? So I mentioned this earlier as well. We want to define the outcome measure before we start. And if you can't measure it, you can't know. You say, well, how do I measure it? What am I looking for? Is this lab data? Is this, some kind of imaging? And it depends. It depends on the situation. It depends on the patient. It depends on the peptide. So for most of these, we don't necessarily have a biomarker that we're going to follow. For some, there are labs that you do want to be checking before you start and along the way. But a lot of times it is looking at the patient's symptoms, their recovery, and how they respond. And everybody can be a little bit different. So again, as I was just saying, we really want to measure something. So it could just be the functional outcomes. And honestly, I think that is the most important one much of the time. So we define it and we track it. Pain scores, function scores, range of motion, strength testing, rehabilitation milestones, return to certain activities, body composition. So I think this is a huge one. And it's been a great addition to my clinic to have that body composition analyzer there, that even if it's not a weight loss goal for the patient, if it's a body recomposition, or depending what they're using a peptide, even if they're using a peptide for something else, it is something that we usually incorporate into every visit and every follow-up visit. And then it is something that you can pay attention to. You want to know their lean muscle mass. You want to know their visceral fat deposition. And, aside from having a more formal DEXA scan, it's a good way to be able to track some things as you follow these patients. Of course, metabolic and inflammatory markers. So there are absolutely lab values that we pay attention to, depending on the situation, depending on the patient, depending on the peptide. And then, of course, lastly, performance and recovery, training capacity, sleep quality, all of these types of things are also measurable outcomes, things we can document, things we can track. And I think that's super important as you go along this journey with any of your patients. So the next super important thing is which molecule, but it's where it came from. So I spent 21 years in the operating room, and nothing touched one of my patients without a lot number, sterility documentation, and a chain of custody. And this wasn't exceptional quality. This was the minimum. So you enter this world and you find patients ordering things from who knows where, injecting powder purchased from websites that they have to reconstitute themselves, that's labeled research only, not for human consumption. And this is so concerning. And I will say that I do have many patients who have seen me over these past 6 months who come in quite honestly frightened about things that they have seen online, or that other friends of theirs are doing, or other guys at the gym, or whatever it might be. And they have definitely sought me out or sought out a medical practice because they feel safer. They feel, reassured that they are under the guidance of a physician, that they know that what they're getting is what they think they're supposed to be getting, and not something that they're unsure of. And I think that is one of the, when I'm talking to a patient about peptides, that's one of the big things right off the bat. We discuss two main areas first before we get into any individual compound, and it's the evidence and it's the sourcing. And so by talking to them about the use of a pharmacy, a 503A compounding pharmacy, immediately we can kind of take that off the table as a concern. The gray market gives you none of the things that you need. No identity testing, no sterility or endotoxin testing, no potency assay, no chain of custody. So that's why I use the 503A compounding pharmacy. That's all I use. Thrilled to be able to work with Optimal Balance. And you need everything that they provide: regulatory foundation, analytical documentation, certificate of analysis, potency, sterility, endotoxin testing. You can look at everything and track everything. You have sourcing transparency, and you have a clinical partnership. You have a pharmacist, you have other representatives at the pharmacy who are there for you and there for your patients to answer questions and take care of any issues that arise along the way. And it's been a wonderful relationship for me thus far. So when you're looking at pharmacies, these are the things to take into account. Licensure. So are they licensed in your state or states where your patients reside? Accreditation and compliance. All of these things are important. USB 795, 797. Certificate of analysis. Would you send me that on request for a lot, including potency, sterility, endotoxin testing? API sourcing. Where does the active pharmaceutical ingredient come from? Can you document it? Beyond use dating and recall processes. We want to know peptides have a lifespan. We want to know what that is, and we want to make sure that the storage is appropriate, the shipping is appropriate, and we want to have some recall about that. So I think the real argument here too is if I say no, that doesn't necessarily mean the patient is not going to keep going after what they want. They'll order it anyway. So writing a prescription through a licensed 503A pharmacy is how this stays inside medicine. It's how we try our best to keep these patients safe. I find many, again, as I said, seek me out for exactly this reason. And I'm so glad that they do. So this is not a commercial position. This is a patient safety position. The choice is not between prescribing and not prescribing. It's between a regulated clinical pathway and an unregulated gray market that the patient is already aware of because they've seen it online, they've seen it on social media, they have friends that are doing it. So let me tell you what peptides are not. They are not magic. They are not substitutes. They're not proven regeneratives, and they're certainly not shortcuts. But let me tell you what they may be. Targeted biological signals, adjuncts to comprehensive care, future precision tools. And I think the promise of this should motivate better research. It's not lowering our standard of care, and it's not lowering our standard of evidence. So intellectual honesty and clinical rigor are not obstacles to innovation. They are the path to it. So I think the future is not simply repairing injury. It's not only about fixing what's broken. It's about creating humans who are harder to break and better equipped to recover when they do. So I really think that recovery, performance, optimization, these three buckets that we talked about earlier are so critical and so critical in the future of orthopedics and where peptides may fit. Recovery, supporting that biological environment after injury and intervention. Performance, sustaining adaptation, capacity, and resilience throughout the years. Optimization, preserving muscle and hormonal environment that will determine patients' durability over decades, because that is what they're searching for. So I think, again, peptides may become a very important tool and part of our toolbox. They're not the toolbox itself, but they're super important. So would love to take any questions. That comes to the end of what I have to say. And I thank you so much for your attention.
Awesome. Thank you, Dr. Towsen. Thank you for such a insightful and inspiring discussion. It definitely made it easy to understand why there's so much excitement surrounding peptide therapy and the possibilities of recovery and optimization and performance. We definitely have a bunch of questions in the chat. So let's get to it. So
Okay.
what is your take on intra-articular joint injections?
Yeah, great question. So, I mean, there's a little bit out of literature out there about intra-articular injections of BPC 157. I have not done that yet. I have used only systemic, so subcutaneous injections. Like with much of the peptide literature that we're discussing, there is no proof that it is necessarily superior to a systemic approach. I feel like many of the patients that I've treated thus far, quite honestly, have had numerous areas of, achiness or arthritis or whatever it may be, such that a systemic approach was absolutely better for them. So I think that's not really been shown. While there are some studies that talk about intra-articular injections or site-specific, even if it's not in a joint, around the area, whether it's an elbow or a shoulder or whatever it might be, around the site of injury, there's no proof as of now that that is superior to the systemic distribution.
Any experience with BPC 157 side effects?
I have not seen anything as of yet. Again, I'm 6 months in my clinic, so maybe I don't have the longest, track record so far, but I've not seen anybody have any trouble with it. And in fact, I've seen just really overall good results with improvements, sometimes in people who've had quite chronic orthopedic issues that have been going on. And sometimes also, interestingly, going back to the other question, some very specific areas. So even with systemic, subcutaneous injection, a systemic approach, I've seen people with isolated joint issues get relief from that, from the use of BPC 157 systemically over a period of time. That's my own personal experience too with my arthritic knee. So I have not seen any true side effects. I have definitely seen variations in how much improvement people get, though. With certainly, like almost any other treatment we do, some people getting better improvement, more noticeable gains than others.
What's your take on peptide blends? There's a lot of debate and limited technology available to, really test this stuff. But do you have any particular opinion?
So I've had experience using blends, including BPC 15 that include BPC 157. So I have had success with it so far. I feel like the blends that have been put together are put together for a reason, because there is a synergy there. There is complementary effects. So I've had experience using the Wolverine blend, the BPC 157, TB 500. And I do feel like those are certainly complementary compounds, and they're often asked for in that way, not to say that just because it's asked for, that's what you're going to do. But I think in the setting where we're looking at a musculoskeletal, injury or situation, it's a good option. I've also used the KLOW blend that includes BPC 157, TB 500, GHK copper, and KPV. I've actually personally used that one. Once again, I think there's synergy amongst those four peptides, and if they're able to be blended together and it does not affect their potency, the nice option there is if they're synergistic, then you can get multiple effects that are working together with one injection. So let's not forget that these peptides very often are injected multiple times a week, and some patients, although they can get used to it, are a little bit, skittish about injecting themselves, at least at first. Some are, some aren't, but I think it's nice sometimes if you're able to get the effect of more than one peptide through one injection. So with the Clo blend, again, I found some very good results there as well. Some people have also found the effect on, their skin and hair with the copper peptide. The KPV with an anti-inflammatory effect and some additional gut support, I think, has also been helpful for people. So I have experience with those blends. I have only on a couple of occasions so far used CJC 1295 with ipamorelin. So I think, again, in that instance, when there are two peptides put together that can, safely and be structurally sound in doing so, and they're complementary to each other, I think it's a good option for people. And I've, again, in my experience thus far, not felt as if any effect was lesser because of a blend. So for example, I've had some people on BPC 157 by itself, or blended with TB 500, or in the Clo blend, and I can't say in my experience thus far that I've seen like a lesser response if we're looking for some musculoskeletal improvements for a chronic musculoskeletal complaint, and someone who's on the Clo blend versus someone who's just on BPC 157.
Are there any non-contraindicated patients you wouldn't prescribe at least a course of tesamorelin to that was looking to optimize their healing and joint health?
So if they weren't on the hard stop list, I don't think, they would need to be. So my criteria, I basically have a pretty like strict or stringent like clinical framework in my practice. So I've kind of alluded to it along the way, but I'm a stickler for the foundational level. So every patient that I see now, first of all, the initial consultation is long. We take 90 minutes and we really establish a great baseline there. We want to make sure that they are doing things that are, as best they can to optimize themselves at the foundational level. So as far as a non-contraindicated patient, so someone who is not on the hard stop list, the only reason I wouldn't prescribe a peptide is if we haven't gotten the other levels optimized as best we can. So if someone just, wants that tesamorelin because they think that that's the answer to their body composition, but they're not going to be going to the gym at least twice a week, and they're not going to pay attention to the nutritional guidance with their protein intake, et cetera, or even if they wanted it again a little bit more for something along the lines of tissue healing, I think we just need to, make sure the other things are optimized, and then as best we can. And then at that point, it would be an option for sure.
Two-part question. This one comes up a lot. Can you discuss contraindications with cancer? And I don't know if you want to go through.
Sure. I mean, I think part of the problem or the issue is we don't know, right? So I think even in the animal data, our preclinical data, there's nothing there that would say or would prove that, for example, BPC 157, which gets a lot of the talk about this, would cause cancer. Of course, with the thoughts of, how it can potentially work mechanistically with cell proliferation and angiogenesis, there's legitimate and understandable concern that if there is an unknown malignancy, are we feeding that tumor? Is that going to proliferate along with whatever tissue damage elsewhere we're trying to heal or help heal with this peptide? So, we don't know. Nobody knows, right? So I think that's the answer. So if someone has a known malignancy, of course, that's on the hard stop list, right? If someone has a history or has, a concern, that's a question that maybe, again, you have to, depending on the situation, it's a risk benefit analysis. If someone has a history of a cancer and they've been cancer free for, 10 years, it was cured, there's probably still heightened concern and raises a bit of a red flag. But to say no to someone, if they don't have, their own preconceived concerns, to say no because of that potential risk, I wouldn't do that. We'd have the discussion and say, we just don't know. And if there was something that we had ultimately missed, I mean, there's no way I can send everybody for like a full body MRI or anything like that. I mean, obviously our system doesn't really support that. So the thought behind how that, that peptide or some other peptides could potentially cause a tumor to grow more quickly, it's there. I mean, we can't erase that. That's a possibility. But, at this point, there's no proof that it causes cancer, and we can't say for sure that it would even cause a tumor to proliferate faster than it otherwise would.
Now, kind of a small pivot to side effects, and maybe touching on, blood sugar, cholesterol, blood pressure, maybe just starting maybe with the growth hormone secretagogues on the blood sugar.
Yeah, for sure. So, I mean, again, things that we need to monitor because it can be affected, it can be raised. We need to, start with baseline labs with fasting glucose, fasting. I mean, these are things I would normally get: fasting glucose, fasting insulin, hemoglobin A1C, IGF-1, and realize that, if we should monitor these labs at least at 3-month intervals, is in my opinion. And if we're starting to see that these numbers are trending in the wrong direction, then it's either dose related or it might be a time to stop or take a break. There can be some fluid retention effects on blood pressure as well. And so these are all things that, again, it's with any peptide, and different ones bring different considerations with them, of course. It goes back to the monitoring. I mean, honestly, it goes back to like good, solid medicine, I think. And it goes, the labs that we order, while you may not need to ultimately do them as frequently, I think in the early stages, you need baseline, and you probably need 3 months. I mean, you may not need sooner than that. You need to monitor. I see patients generally every 6 weeks in the beginning, and then spread that out more, and certainly have an open line of communication with people, in between that time frame. So yeah, I mean, I think it's possible. It's possible to see these things. So we just need to be sure that we are at good monitoring intervals, and then we either have a time to adjust a dose or perhaps stop. And maybe it's not stopping for good. Maybe it's stopping for a period of 4 to 8 weeks, and then, potentially starting again and again, maybe at a different dose, or optimizing some other things if possible.
How do you balance the use of peptides versus menopausal MSK conditions?
So, in any of my like perimenopausal or menopausal females, the first step 100% of the time is hormone therapy, menopausal hormone therapy, unless there is some true contraindication why a woman couldn't be on it. So, my first goal is to try my best to get hormones balanced, and I will say that in general, for the musculoskeletal conditions that we are most concerned about, that women deal with in their menopausal time frame, perimenopause or menopause, include things like just generalized kind of myalgias, muscle aches and pains, kind of this musculoskeletal syndrome of menopause. Of course, frozen shoulder, which I saw every week in my office for 20 years and never once asked a woman about her menopausal hormone therapy, never once. So what a failure of, again, staying in your lane in orthopedics, but that's the truth. And, of course, the osteoporosis, question. So that's where we need to optimize the hormones first. Beyond that, if we are at a good level there, certainly we could consider something like BPC 157 if there were musculoskeletal complaints that were, still present above and beyond optimized hormones, and hopefully also, some strength training and other things that might be able to help.
What A1C would be the limit for a hard no to start?
Um, so I don't know. Anything, I would say anything above 5 or 6, even. I would, I guess, yeah, I wouldn't want it. It would it could be on the higher end of normal, but I wouldn't want it any higher than that.
Especially for growth hormone peptides, right?
Yeah. Yeah.
Yeah. Do you have any preference of peptides for nerve pain?
Um, I would probably still go back to BPC 157 and TB 500. I've had a little bit of that already in my, in these 6 months that I've been in practice, where a couple people that I've seen have had some chronic kind of like nerve related issues that were causing pain kind of in their shoulder, upper back, scapular region, primarily is what I've seen. And that's what I've tried thus far. So I think there's a role for them in that situation.
So you talked about BPC 157 and TB 500 thymosin. Do you have a preference for how do you make the decision if you're going to use, I guess, BPC 157 by itself or decide to do one of the blends?
Yeah. So usually it depends on, I talk about it with the patient too. So I would say it's hasn't been that common for me to use BPC 157 on its own, but I have. And I think if someone has a little bit more of something on the acute side, I'd be more likely to do BPC 157 with TB 500 together. If it's something that's more chronic in nature, I might do the BPC 157 just on its own. I think depending on the full picture, I've had several patients that have had like multiple things going on. And a lot of my, female patients, not that the guys aren't interested in it too, really like the idea of the copper peptide a little bit more for the potential aesthetic effects. So when we start talking about the potential of using a blend, then it quickly extends to the Clo blend, because that's what Optimal has, and because it includes the copper peptide. And many of my female patients, especially, but also some of the guys, are quite interested in it too. I'll be honest with you. They like that potential addition, since we're going to be, again, doing an injection anyway. And then the KPV with some added anti-inflammatory effect, is certainly helpful, and anything for gut health support. So I would say right now, and at least over these past few months, I've been really kind of like, not across the board, but very interested in using that particular blend. If my goal is 100% just a musculoskeletal issue, there's nothing else going on, and it's something a little bit more chronic in nature, then that's usually the time for BPC 157 on its own.
This comes up quite a bit, is how each physician structures their lab requirements, right, for different programs. Do you have
Mm-hmm.
specific, hormone panels, metabolic panels for all peptides, or where do you draw the line on?
Yeah. So, I mean, generally speaking, when patients come to me, again, my practice is health optimization. So while some patients certainly walk through the door and they, just already have a peptide that they're coming in for whatever specific problem or specific goal they have, usually we're looking a little bit more at the broader picture. So generally speaking, what I like to have, and it's not always what I get, but what I like to have is a just kind of a generalized like metabolic panel, lipid panel, CBC, hormone panel, all thyroid panel, and then those kind of basic things at a baseline when patients just come in to see me. If they've had labs within the past 6 months to a year, I'll look at those or start with those, and then depending what our plan is, if we are doing something like a growth hormone secretagogue, then I may order, additional things at that point if they didn't include, and some of the basic general labs wouldn't necessarily IGF-1, or maybe if they didn't have a hemoglobin A1C, if they didn't have, some other things that I would want, I would try to get that up front. And then usually if for just starting hormones, which is a little bit of a separate discussion, a lot of times if they don't have a hormone panel right off the bat, it depends where they are in the continuum of menopause or perimenopause, or potential testosterone decline in a male. We might start something very low dose and then check labs at 3 months, and then of course we'd be checking hormone panels there. Moving forward, I usually would do 3 months and then maybe 6 months if someone's on a GLP-1. I do have some standard, small, panels that we will check at 3 months. And then again, I'm just getting to that point now, like at 6 months, and then try to space things out, after that point. So I think it does vary for sure, depending on the plan. And, I would say the only peptides really that I am using routinely now that don't really have lab biomarkers for, would be the BPC 157, TB 500, or the Clo blend. Even like there's not, other than perhaps looking at copper, but we're not using that Clo blend more than like 12 or 16 weeks at a time. So I'm not really so worried about the potential for any copper toxicity.
In your practice, do you encounter, long COVID, chronic fatigue syndrome, and apply peptides to those patients?
I haven't yet. I mean, that's not to say I won't, but I really haven't yet.
So Lyme, kind of same situation. Haven't encountered that.
Yeah, I really
Yeah,
haven't.
you run more of a optimization
I
clinic, not so much
do.
functional medicine. So
Yeah, exactly.
I'm sure they'll pop up. But in
I'm sure they
terms of
will. I'm
yeah,
sure everything will pop up. Who knows what I still will see, but yeah.
do you have any opinion on thymosin beta 4 being superior to TB 500 or any preference?
I really don't. I haven't prescribed thymosin beta 4 at all yet. It's only been the TB 500. So I don't necessarily have any experience to draw from there. And like, as far as, what we have to draw from on the evidence side, I'm not sure if I can say there's anything that shows superiority unless it's something I don't know about.
Have you seen a difference in response between tendon, ligament, and muscle injuries, or does it look the same across soft tissue for
With the
PPC?
use of BPC,
Yeah.
yeah. So, so far I've seen, I would say fairly equal response. And I've had patients with various different things. I've had patients using it more for arthritic type complaints. I've had patients using it a little bit just for generalized, let's say like workout recovery. So I put that a little bit more, obviously in the muscle or maybe tendon category. I've had some people more with like a little bit of like maybe a chronic ankle sprain or chronic plantar fasciitis So I've had not as much maybe true ligament damage or ligament things, maybe this chronic ankle instability to some degree or chronic ankle pain, but more so with tendon, muscle, and then even with with cartilage, with arthritic joints. So that's what I've seen most, and I would say I've seen fairly equal response in people thus far. And again, and it's been variable. By no means can I say that like BPC set 157 is the magic cure for everybody. Not at all. But nothing we ever do is, right. So, but I would say in general, the results have been really favorable. And I think I've had some people be quite honestly really pleasantly surprised that had come to me. Even had a couple of my former partners send people to me who had, chronic things, had gone through all of our standard orthopedic treatments. I can use my own personal story a little bit too. I mean, I've dealt with an arthritic knee for about 10 or 12 years now, and I've gone through all of our standard, orthopedic treatments. And I will say that my time on I did the Clo blend, was very, very helpful for me, noticeable. I mean, and so it's been very rewarding also. I mean, and I'm an orthopedic surgeon at the core. I think everything that we do is great, but if there's more tools in the toolbox, again, why not? And so the clinical feedback, the response I'm getting right now from patients is in general so favorable, that it's been really exciting to see. I mean, I've had some people with, again, long-term complaints, that within, I'd say it varies, but again, within maybe 2 to 4 weeks, I've had people even before follow-up visits, like emailing me and saying, oh my gosh, I feel so much better. So it's interesting for sure.
For the midlife person or midlife athlete with declining GH, when is a secretagogue the right tool versus just fixing their sleep and training?
Yeah, I mean, again, like, great question, and I don't know that there's like a exact right answer. I'd say when I see patients, I definitely want to go down that optimization road from a foundational layer first. And I would say usually we're going, at least, it depends where they start, right? So if someone comes in and they really do need to work on sleep hygiene, they really do need to work on some of these other things. My goal is to at least give that 6 weeks of like a concerted effort and say, okay, these are the things we're going to target first. It's pretty, I mean, honestly, it's pretty rare for me to prescribe any peptides before I've been seeing someone for at least 6 weeks. I mean, typically there's other stuff to do lower down on that pyramid. And even someone who comes in who, says they eat healthy or they work out, routinely or whatever, when you dive into that, trust me, I mean, we dive into it because I'm with these people for 90 minutes and you uncover that, well, hey, there's lots of ways we can do better. So I do think at least 6 weeks, if not 3 months. And then it depends, because also sometimes some of the complaints that you could 100% use a peptide to try to improve, you can also potentially improve with hormone therapy and, getting that started first. And sometimes there's a reason not to, or sometimes there's a patient preference, for some reason not to. And that's also acceptable. I mean, it's a discussion that we have, but again, I almost never start with a peptide. Someone has to be like really, really off the charts optimized, already by the time they come to me to do that. So I'd say, they've got to be sleeping, at least trying to, fix their things on their own for at least like 6 weeks or so, before we add something in.
How do you handle the patients that are, they come in and they've been using gray market peptides and on
Yep.
their own with no medical oversight? Do you
Mhm.
require an offboarding, and how do you handle that conversation?
Yeah. So I've only seen a small number so far, which is good. I've seen a lot of people who like are heading that off at the past, which I alluded to earlier, who are seeing their friends or other people, who are trying to convince them, well, hey, let me get you the stuff from where I'm getting it or whatever. And it's been a hard stop for a lot of patients who have come to see me and say, no, like, we didn't want to go that way. I certainly have seen a handful of patients though, who have been either, getting whatever from wherever, or been, sometimes also even with like hormones, been doing some things with like online clinics and whatnot that have not been all that well monitored or supervised. So I will say I generally recommend stopping. I kind of recommend like a fresh slate. So, if someone does come in, we look at what they're doing and, if they can even attribute, like, are they actually feeling better, or have they actually achieved a goal, or are they, are they working towards some goal, and like, why were they, taking these specific things? And sometimes they don't even know, or they can't even tell you. I mean, they were taking it because their friend was taking it. So my general, rule, if you will, or the way I've gone about it, is honestly to pretty much stop other things they were doing, or at least, simplify the situation. And if there was any peptides that were not, prescribed by a 503A pharmacy, I recommend that they just stop. I mean, you don't even necessarily know, what they were doing, what they were injecting. So we stop, we, get the lab work, we start over. And I've had to do that with some people with hormones as well, with like crazy lab results or just things that were just, you know, I don't know. Not, and again, I'm not the world's expert. I've not been, in this space for so long, but I can certainly see where things have been going wrong for people already. And so we kind of just start over.
There's been a lot of discussion on this topic, nationally with, tracking physicians tracking outcomes. Do you have any perspective on that, tracking the outcomes of safety and efficacy of 503 a peptide? Should this be something that all providers should participate in?
Well, I think it would be amazing to, have as much, communication and participation and whatnot as we can from everybody who is prescribing. And I think that's part of the way we move this forward, right? So I think that, registries and like tracking things from, not only with pharmacies, but, with outcomes and whatnot is the way of the future for peptide medicines, the way to like understand things better. Are we really going to have randomized controlled, human trials anytime soon? Chances are no, right? So I think if we can, as much as possible with registries or whatever, with, docs like pulling together their results and things, and tracking what they're doing, I think it would be a huge asset. And again, it's not, we can't interpret that data exactly the same way as we can a higher level of, of evidence, but it's still helpful.
On MOTS-C, you talked about being really enthusiastic about it and its, enthusiasm further than the data. How do you choose those patients?
Yeah, I haven't used much of it yet, but I think again, it's a little bit higher level on the optimization, scale, if you will, for me. So I think, I'd be curious to see a little bit more, and I need to like even research it a little bit more myself, but it is an exciting one for, that kind of next level of, metabolic, but also like orthopedic help again. And the thoughts behind that menopausal woman, especially, I know it's getting a lot of chatter there, with potential help with osteoporosis, with potential help, even with arthritic joints, potential help on the metabolic side, the exercise mimetic, all of these things with, preserving muscle. I think it's very interesting, and a little bit next level for me right now because I'm just exploring it a little bit more. But I think it has, good potential in orthopedics, and even with some of there's one animal, model about osteolysis as well. I mean, for our joint replacement surgeons. So um, that one I need to even study more myself, but like I'm super excited about it.
Have you seen a patient's joint symptoms improve from weight loss alone before any other peptides got added?
100%.
Yeah.
Yeah, absolutely. All the time. I
Mhm.
mean, and I mean, we saw that for years. I saw that for years in ortho before I got here. I mean, it can be a hard, thing for people to achieve, of course, sometimes, but, and especially as people get into midlife and do really struggle with their metabolic changes, hormonal changes that, probably 99 times out of 100 or 95 times out of 100 lead to some increased weight gain, maybe not, significant, but for some people, yes. I think it can sometimes be difficult for people because, and I hear this all the time, I'm trying my hardest, I'm doing everything right, I'm eating my protein, I'm strength training, and I hear this often, and I think, it's true that we are sometimes just get a little bit stuck with the metabolic changes we have. So if hormones don't do the trick, I am also a big fan of tirzepatide, use it often, used it myself. And so while I think it is absolutely possible to, lose weight without the addition of a peptide, most commonly would be, a GLP-1 or tirzepatide, I think they are really, again, helpful tools as well.
You have, other tools in your office to, determine body composition. How's that helped you build your practice out and make better decisions on peptides?
Yeah, it's been amazing. So I have the Staiku. body composition scanner, and it's amazing. It's been, definitely able to kind of like elevate what I can do in my practice. Unfortunately, it was delayed getting to me, so I didn't have it in the first few months of my practice being open, and I felt like it was a real, it was kind of a real deficit for me. So it's been amazing in a lot of ways since I've had it. So patients, on their first visit, whether they have a weight loss goal or not, many of my patients do, in conjunction with other things. It's been amazing to be able to get them on the scanner and be able to really truly see percentage of body fat, to see the amount of visceral fat. And it's eye-opening for the patients too, I will tell you, because I mean, most everybody can sense if they're, if they're overweight, if they're where they don't want to be, a lot of people will have that central weight gain in midlife, that, belly fat, the visceral fat. But I don't think sometimes people realize the extent to which they do, or, when you get them on this scanner, then it also has numerous screens we can go through. It does this 3D body scan, it does numerous measurements, and then we can go through and look at like also ranges as compared to the population in general. There's many screens we go through. And so I think, first of all, it's helpful then to be able to track this and compare. It's more data points, it's more information, and it's much better than, as we know, as far as looking at just the number on the scale. And then I think it's also very eye-opening to patients. Like, they love it, first of all, or they something like, I don't know if I'm going to love it when I actually see what it looks like, but I think they do love it. And then, the study is very nice. It emails the patient a report and everything too that they can have. But I think it's very eye-opening for some to then actually see and like look at these numbers and look at like, oh gosh, my body fat percentage puts me in this at-risk category, because you can look at a screen where you see, the different like kind of stages of like at risk or average or fit or athletic. And then you can use this little slider and see, what percentage of fat loss, not weight loss, but fat loss is going to change that for people. And it's I think it's great. I mean, and I think it's absolutely essential. And again, I wish, I didn't have those few months where I didn't have it. But that being said, that's the past and moving forward. And now we can do, and even patients that I saw earlier on, we're doing it at their follow-up, we're doing it at consistent follow-ups. And then even if, weight loss is not the main goal, because it's not the main goal for every single one of my patients, even if it's, still body recomposition, trying to build more muscle and still maybe lose a little bit of like stubborn visceral fat, or just try to watch your, the muscle composition change, lean muscle mass change. If the goal is just let me build muscle, get stronger, for my function and for my longevity, it's just a great tool. So I would, any practice like mine, I mean, like I highly, highly recommend it. I don't think you should be doing it without it.
Well, Dr. Towsen, we're just about time. This has been, an amazing evening. Thank you so much for joining us and giving this awesome, insightful talk. Thank you to everybody that joined us this evening. We really, really appreciate it. And as we wrap up tonight and continue the series that we're doing on peptide education, be a great time to announce our next event coming up, next peptide webinar coming up Wednesday, September 23rd. Join Dr. Frederick Brown, founder of HealthSpan Method. So he'll join us from peptides to transformation, showing how providers can move from understanding all about the peptides to really thoughtfully integrating them into a broader clinical framework that creates meaningful changes for patients. So continues the series of taking these amazing perspectives of practices like Dr. Towsen tonight, and the previous ones we have had, and then Dr. Frederick Brown coming up. So if tonight left you excited about what's possible, you will not want to miss this next session. So please remember, everyone must register for the event, whether you plan to attend live or receive the recording. We'll be sending out the recording hopefully before the end of the week, and we'll also be posting it on our YouTube channel, and we'll send you this invite as well. So thank you very much, everybody. Really appreciate it. Thanks again, and have a great night.
Thanks.